All right. Good morning, everyone, and welcome to the 2022 PI Conference. We'll be getting started in just a moment. We want to let everyone know that Spanish interpretation is available for this session, and you can access the Spanish language line by clicking on the world icon in your Zoom toolbar. My name is Emma Mertens, and I'm the Program Manager of Community Relations at IDF, and I will be your moderator for this education event. This morning, Dr. Charlotte Cunningham-Rundles will be presenting on the topic of Common Variable Immune Deficiency, or CVID. There will be time for questions at the end of the presentation, and you are welcome to submit any questions you have via the Zoom chat. Charlotte Cunningham-Rundles is the David S. Goetzman Professor of Immunology, Professor of Medicine, and Professor of Pediatrics at the Icahn School of Medicine at Mount Sinai in New York. She established and directs the Immune Deficiency Program at Mount Sinai, a leading referral service to evaluate and treat infants, children, and adults with a variety of primary immune deficiency diseases. She serves on the medical advisory boards of the Immune Deficiency Foundation and the Jeffrey Modell Foundation. She is a longstanding member and is currently an officer of the Expert Committee on Inborn Errors of Immunity of the International Union of Immunological Sciences. Welcome, Dr. Cunningham-Rundles.
Thank you very much for that very nice introduction. Today we were going to talk about common variable. Of course, you can see in a moment, this is a diagnosis that needs to be unraveled because there's really so much to say about it. If we're going to talk about this, first of all, we have to sort of say, where are we going? And this is the long title that I would like to use, which is, this is the history of CVID as a non-genetic clinical syndrome, which is where it began some time ago. And then at the moment, we believe that it seems to be evolving to sort of single cell diseases that are put into this category, really because now we understand a little bit more about why those B cells don't ever mature into good, well-performing plasma cells. So what are we going to talk about today? First of all, the diagnosis. Secondarily, the clinical features, basic treatment. What else? What else happens? Complications, for example. And why those antibody-making B cells, you can see those blue, I guess, circles over there. Those are supposed to be B cells making their lovely antibody. And what they're supposed to do is do that lifelong. They turn into plasma cells once they've become fully educated. And those plasma cells then live in the bone marrow for years and years and years. But we want to know, how do B cells work? And what happens when they don't work? Why don't they work? And what are we going to learn about this next? What else can we think about? The antibody deficiency diseases really began right in the middle of the last century in 1952. And this was at the Walter Reed Army Medical Center, where Dr. Ogden Bruton saw an 8-year-old boy who had repeated episodes of pneumococcal bacteremia. Very, very sick child. And he had really no gamma globulin in his blood, which Dr. Bruton was really the first person to notice. Honestly, he thought that it was going to be high because of all the pneumonias that the child had had, and that turned out not to be the case. It was exactly the opposite. He didn't have any gamma globulin. And because of that, then immunoglobulin therapy was launched, but that was launched really not until this particular time, because people did not know until then that it was possible for a child to have very little gamma globulin in their blood. And so for some time, it was thought to be, oh, that must be a pediatric ailment. That must be something only children could have. And by the way, that's probably only little boys. But that turned out not to be the case. And I really love this report in a way, because this is the first time that it was ever pointed out that not only was it not necessarily children, but also it was not necessarily a little boy. And these things became very important because this is the first case of common variable immune deficiency that was reported. And as you can see by the report, which was in the New England Journal of Medicine, that this particular woman had had a tremendous number of abnormal things going on, lots and lots of infections, abscess, her gastrointestinal tract was misbehaving. She also had some neurologic problems and a certain amount of chronic cough continuing throughout the years. So this is the first patient with common variable described in 1954. And of course, people at the time still had no idea that it could be genetic. Because after all, if you're 54 or 44 in her case, how was it that you got to be 44 with no gamma globulin? So this slide is kind of the massive picture of what the immune system looks like. And starting over on the left, you have the stem cells, which everyone, I guess, has heard about what stem cells are. They give rise to all the other types of lymphocytes and white blood cells that you have in your blood, and also to the red cells and also to the platelets. But this is the lymphocyte family over here, where the lymphoid cells turn into, with a lot of maturational influences, turn into the antibody making cells, which turn into the plasma cell, which makes all the gamma globulin over here. And also some of them then mature into T cells. Some of those stem cells turn into neutrophils. Those are the white blood cells that eat bacteria and get rid of bacteria in your blood. And then of course, red cells and the other cells as well. So this is where gamma globulin comes from. It's actually coming from these extremely hardworking cells that live in your blood, your spleen, your bone marrow, and your lymph nodes. And they're busy all day making lots and lots and lots of gamma globulin. The IgG, the IgA, and the IgM. It's a major energy proposition. And this is that family of antibody producing we're going to talk about today. We spend a lot of time thinking about common variable. I know that anyone in clinical medicine does, partly because if you think about who is going to be appearing in the medical office, the commonest form of immune deficiency in the clinical office is actually common variable. That's that big yellow section of the pie there. So common variable is about 30% of the business at Mount Sinai. And certainly this is really very much like the books that will be shown, pediatric textbooks, even medical textbooks. This isn't just what Mount Sinai has. This is basically the data in everyone's office, which is the defects of antibody production. You can see here is IgG deficiency, here's IgA deficiency, here's X-linked gamma globulinemia. You're moving on around, about 60 to 70% of all the immune deficiencies that you ever see have to do somewhere with not making the right amount of antibody or not antibody that's very good material. I'm very much a believer in trying to get this right, because when you are in the office, you actually want to be sure that what you have is the right diagnosis. And to be honest, it's really a lab test, to be honest, a bunch of lab tests usually, which is the IgG must be quite low, and one or more of the other IgG gamma globulin molecules, or the Ig molecules, have to be low as well. It can be IgA and or IgM, but it's usually IgA and IgM, usually both, which tells you that those antibody B cells just really don't know how to do anything right. The other thing is you generally wait until a child is older than 2, and frankly, it's better even older than 4, because children don't have as much gamma globulin in their early years, and it would be not reasonable to say it was common variable in a young child whose system simply hadn't become entirely matured yet. And so we wait a bit of time in order to be absolutely more convinced. And then the third thing, absolutely vital, is you have to really show that the antibody responses to vaccines or infections that you may have had, such as the measles, mumps, rubella, tetanus, diphtheria, pneumococcal vaccination, really didn't work. Your body saw the vaccine, but your system said, I'm not doing that. I'm sorry, I can't. And then you have to think very hard, because you have to think, well, could it be something else? Could it be another medical reason why the gamma globulins are low? So how common is CVID? Honestly, we don't really know. The textbooks say about 1 in 50,000. I think a better guess is at least half of that amount. And if that's the case, then there's 14,000 in the United States. I really don't even know if that number is anywhere near right. I honestly don't. I know at Mount Sinai, I've seen somewhere around 700 to 800 patients with common variable immune deficiency. So it makes me think maybe that number is still rather skimpy and perhaps not even right as well. Now, what else do we know about it? Generally, women are diagnosed a little bit earlier. Females are diagnosed just a little bit earlier than guys are. I don't know why that's the case, but in our particular circumstance, males seem to be diagnosed somewhere just after their teenage years, 20, 21, 25. It's not extreme, it's not uncommon at all for a woman to be diagnosed when she's 39 or 40. And I think we don't know the reason for that. And that, of course, has made everyone assume that it cannot possibly be genetic. If it's genetic, how come you had to wait until you're 30 or 40 to know that question? But it's also true that around 20% of the people that diagnosed with CVID are actually much younger. And for the people who were listening, I'm sure that many people in this group also have suffered because they were diagnosed rather late. So if we say the date at which the diagnosis was applied in the chart might actually not even be right. If you've already been sick for 10 years, then you can see how that would be really a very skewed number. So diagnosis delay is very, very common, and people have looked at that very carefully. 6 to 8 years, and in my experience, it can be even longer, as long as 20 years actually, can take up a lot of time before someone is really thinking, oh gosh, I guess the gamma globulins might be not okay, and finally test those gamma globulins. Now, this is where the gamma globulin levels commonly go. This is in the United States. This is USID net data. And it tells you that here's the IgG level for so many of these people. It's somewhere around 200 or so. It's a very good idea if you have common variable to have an idea of what your starting level of gamma globulin is and have an idea of where it is when you're getting treated. Now, what's normal, of course, is a great deal north of this. It's more close to 800 or 900. So 200, as you can see, is really not much gamma globulin. This is the IgA, which is again very low. If you think that normal is more like 50 to 100, and the IgM is also quite low. Again, it should be up to somewhere around 100 or 200 or so. And so these are the numbers that were USID net numbers, and these are clearly extremely low. But there's a range, obviously. And what usually happens? Usually, as you would expect, because you don't have enough gamma globulin, it would be expected that maybe you would have an infection. And usually that's pneumonia, or it may be something else, just repeated bronchial infections, or perhaps repeated sinusitis. But another thing which is very interesting and obviously strange, which is that why would you have autoimmunity when your antibody making cells don't know what to do and don't make antibodies to proteins and carbohydrates and bacteria, for example? Why would it be reasonable for that antibody making B cell to attack your platelets? And that's something that we've seen. About 25% of my own patients have had ITP in the past, or perhaps autoimmune hemolytic anemia. It's not reasonable, but that's part of the history in our patient group, and we've all noticed this. Gastrointestinal problems are a big deal as well. Many people are diagnosed with asthma or chronic lung disease. And if you move on over, there's all these other additional medical problems that are relatively common. If you talk about infections, what are the commonest infections? Sinusitis probably is number one. Pneumonia is certainly number one, is certainly number two, I would say. And then bronchitis, ear infections, abscesses, and moving on down. Many people have had shingles as well. I'm sure some of the people listening have probably had shingles previously as well. Other things seem to be a little bit less likely, but certainly we've all seen them. So this is a very, for me, a common scenario, and one that I have an extreme difficulty understanding. No matter how long I am working in this field, this is hard to explain, isn't it? This is a 40-year-old man that I saw for the first time when he was 40 or 41 years old, and he had a very bad pneumonia. This is the pneumonia over here on the left side of the chest. And you can see that that pretty much obliterates most of the left side of the chest. And that's basically inflammation material that's circling the extra part of the lung over there. And of course, that had to be drained because it was so bad. But the strange thing about it was that he's got almost no gamma globulin in his blood. And you say to yourself, you're 40, 41, 42. How is it that you have no gamma globulin? How come I didn't know that before? And that's one of the things that we simply have a very hard time understanding. And I don't know the answer to that, because it could be that if we looked at his gamma globulins 2 or 3 or 4 years before, perhaps they were on the slide and going down. But we don't know that. We honestly don't know that. What I do know is that this is not an uncommon scenario to be in this age group and yet be very, very low in gamma globulin. This is what bronchiectasis looks like, if you have heard that name. And this is a patient of mine who, again, had extremely low levels of gamma globulin. I think for a long time her cough was said, well, you're a smoker, so that happens. But actually, smoking doesn't give you this inflammation of the airways. These white tubes here are the bronchiectatic areas. They're swollen areas of the bronchial tube that are inflamed, and that's why the lung looks that way. This should be relatively dark and not have these strands of whiteness there, but that's what bronchiectasis looks like. And that's because this lady had had repeated respiratory tract infections. She had a few pneumonias, but she was chronically colonized by these particular bacteria here. And these are the common kinds of bacteria that you find in bronchiectasis. I like this slide very much. Uli Bowman from Germany put it together, but I like it because it says, you know, over time, since we've been using gamma globulin, the amount that we've used has slowly increased. We've really prescribed more and more gamma globulin. I remember in the early days, we used to give around 300 or so milligrams per kilogram per month. And now it's closer to 400 or 600 milligrams per kilogram per month. The dose has gone up. And at the same time, because it's gone up, let me go back to that slide. Because it's gone up, you get more gamma globulin in your blood as well. And I think for that reason, what we have is reduced numbers of respiratory tract infections and also reduced numbers of pneumonias in patients who are on gamma globulin. So on gamma globulin, good doses of gamma globulin, we really rarely see pneumonia anymore. Respiratory tract infections are tremendously reduced, but pneumonia is almost eliminated. And so that's a good part of the story. And once we began to use large amounts of gamma globulin and we didn't see pneumonia anymore and weren't losing patients to chronic lung disease, we began to realize that what we were seeing is something else. And that is that the infection-only phenotype, which is now about 32% of patients, and this is my practice, by the way, about 68% of patients have something else as well. In other words, yes, they have infections, but they also have autoimmunity, for example, or I don't know why that keeps switching. There you go. Or chronic lung disease, for example, lymphoid hyperplasia, where the spleen is really, really large, or the GI tract is really inflamed, and there's really bad problem with getting proper nutrition. Liver disease, granulomatous disease. In a few, we've also seen some lymphomas and other malignancies. And so there's other things that have a chance to make their appearance. In a way, in the clinical world, we really are talking a lot and thinking a lot about, okay, we got the infections under control. Now what? Now what do we need to know? What else do we have to get and make right? And that's where we spend a lot of time now. So the autoimmunity is commonly against platelets, red cells, sometimes against the skin. There's a skin condition called vitiligo, which means the skin gets these blotchy areas of whiteness because the pigment has disappeared. Some autoimmunity with the pancreas, the white cells, the thyroid, the gastrointestinal tract, and the joints. But I would say the platelets and the red cells are probably number one and number two, and probably the skin is number three. So autoimmunity is not a reasonable thing for the immune system to be doing. If it's not conducting its normal business, why on earth is it now attacking its own tissues? And that's another one of those mysteries that we spent a lot of time thinking about. And this is what the gastrointestinal issues look like, which is that about 8% of patients, and at Mount Sinai, we've seen quite a few people with pretty bad GI disease. First of all, of course, you have to think, is it just simply a parasite or a bacteria, a virus infection, or any of the things over here? But we also see celiac disease, Crohn's disease, and ulcerative colitis. And so we have to spend some time thinking about how are we going to treat those patients with those particular inflammatory issues. That's what this particular man has. He has an area of the transverse colon here, which is very, very inflamed. And that's why it looks this way, very patchy on the x-ray that you can see. This is what the nodules look like in the intestinal tract. And that was a fellow that I saw from Michigan some time ago who has these nodules of lymphocytes. They don't make gamma globulin, but they're trying, and they increase in numbers, and every one of them is like a baby B cell that's saying, I will try, but I'm just going to proliferate. I'm not going to make gamma globulin, but I'm going to really try, and I'm going to get bigger and bigger. And of course, that made it difficult because that particular person lost a lot of weight because he didn't have the normal absorptive surface. These are real pictures of patients of mine. And these all are showing very, very large spleen. If If you're not used to looking at an x-ray like this is the area of the spleen over here on the left-hand side. And this is the large liver. This particular person this woman has a very large liver. Her spleen is kind of tucked under the edge of the liver, you can see. And so this tells you that the lymph tissues are actually commonly rather swollen, especially the spleen. And sometimes the spleen actually takes up too much space. And because of that, it also takes up too much blood and soaks up too many platelets and red cells. And there's a way that we get around that. We generally do not suggest a splenectomy, by the way. I have patients who do not have a spleen anymore, but we don't suggest that a splenectomy is the way to go anymore. There's a better way to treat that particular issue. So back to the question. You have these antibody making cells that don't ever graduate from college to make a plasma cell. Sort of they're stuck in their preschool years over here, and they are not really getting out of high school or they're not even going to college. So they really can't make an antibody. They really are not, they're really stalled in that direction and really can't get there. But the question is why? What is that all about? So going back to a moment ago, what I said a second ago, this is what a B cell looks like in your blood. This is an electron micrograph, by the way, and this is the nucleus. These are, of course, are the little organelles that are inside every single B cell that give it all the energy that it needs to turn into this amazing cell called a plasma cell. And every single one of these little loops you can see here is where all the gamma globulin is made. Gamma globulin is about 20% of your serum protein. So if you look at the serum, you can imagine that those cells are enormously busy. And also the gamma globulin in your blood, of course, that's where all the antibodies are contained. And that's really why we talk about gamma globulin. It's kind of an old word, I know, but that's the word that we use to talk about that particular part of the serum protein, which is that material that contains those antibodies. Now, this is what it looks like in the bone marrow. This is a plasma cell in the bone marrow here, and that's what they look like. There's quite a few. Here's another couple over here. And they also function really extremely well in the gastrointestinal tract. You could imagine that in the gastrointestinal tract has so much bacteria there that you should have a lot of lymphocytes in your gastrointestinal tract. And these predominantly make IgA. And it's just crammed with these cells that are capable of doing that very amazing task. Of course, most of the IgA that's made in the gastrointestinal tract is actually discarded, goes out, easily through the GI tract. So what goes wrong? So that's a big operation, isn't it? And you can see Mother Nature cares a heck of a lot about it. 20% of your serum protein and all those cells busily working all day. So what goes wrong? Well, first of all, it's obvious. You could simply have no antibody making cells at all. Or they could say, well, never mind, I can't activate. And the others would be, well, that's okay, I could activate, but I'm never going to grow bigger. And the last one is, well, I'll grow a little bit bigger and I'll try, but I'll never make a plasma cell. And the last one is, I can make a plasma cell, but that plasma cell is never going to make a gamma globulin molecule. I'm just never going to get there. So what about genetics? We talk about genetics. These are filed under genetic diseases. But then you think, okay, fine. If you tell me that's genetics, can you give me a clue? What is that all about? And this is the gene discoveries kind of in the early years. You can see that the A-gamma globulinemia gene, remember, Dr. Bruton talked about that in 1952. So it took 41 years for anyone to know what that was all due to. And that was 1993 that was first described. Hyper-IgM syndrome was only tackled and figured out in 1993. But looking at the other areas, CVID has been sort of an empty ground for so very long, for the last 20 to 30 years. CVID, IgG defects, IgA deficiency, and antibody defects, like where are we? If you tell me those are genetics, can you please put some genes on there? And that actually begin to occur. And this is a interesting picture that says, since the year of 1990, especially since 2010, there's really been a cascade of discoveries. And the ones that are in yellow here are the ones that are found in patients with common variable immune deficiency. So now we have a little bit of an idea about why those antibody-making B cells fail in their job. And so we've been extremely busy trying to figure this out. For one thing, you rather want to know what it is about your immune system that's not working. Maybe we can think of a better way around that. And then number two, you may want to know it for family planning. You might want to know whether another member of your family needs to be tested. And then you look at patients, and this happens to be Mount Sinai's data that we published a few years ago. About 29 to 30% of the time, I can now tell you what the gene would be, which is to me an absolute amazing statement that we could make. 20 years ago, I couldn't have said that. But now 30% of the time, I can give you a pretty good idea. And these are the names of the genes. The names don't really matter very much right this moment. It's just interesting that we can actually put some labels on things. Now, I have to tell you that although 30% of the time I do have an idea, I also have to say, well, that makes me very much looking for the other 70%, because if you consider them genetics, we still have a lot of work to do. That seems very clear to me. Now, this is New York's data, and this means the patients that come to me in New York, which, by the way, are not necessarily New Yorkers. I see quite a number of patients that are from other areas of the United States and also even other countries. But this is still the predominant grouping of patients. But again, apologize for the complexity of this slide. If we take the Mount Sinai data on the far left, I then correlated this with my Swedish colleague, Dr. Lennart Hammerstrom, looking in his Swedish cohort. And as you can see that even though I've tried to color code the genes similarly, you can see the genes that were found in the Swedish cohort that have CVID are actually quite a bit different than they are in the United States. 36% of his patients come up with a diagnosis that we can put a name on. And then if you look at our colleague in Iran, Al-Bassani, we can see that although 54% had relevant mutations, again, they're quite different than they are than the ones in the United States. And these are, in a way, very commonly what we call recessive inheritance, which you might say you have to have two bad copies of that gene in order to have that ailment. In the United States, however, most of the copies of the genes that we see are what we call dominant, which means that only one copy of that abnormal gene is sufficient to say, sure, those B cells aren't going to work very well. So again, what we end up with is a very large number of genes, that's 50-some genes, 60-some genes in 601 CVID patients. If you pretty much add all those numbers together, you can say there's a lot of things a B cell can do wrong. But why? Why so many genes? We started off thinking that everything that should be found would be something wrong in the B cell, right? That makes sense. The B cell is messing up. So why does it take so many? And again, this is a slide which is kind of amazing, and I understand it's kind of complicated too, but that's the point in a way, which is that a B cell has a very, very, very hard life. It really has to do a heck of a lot of chores. It's born in the bone marrow. It has to go into the lymph nodes. And then those B cells have to meet a special antigen or your vaccine, for example. It has to understand. It has to then get committed and get a lot of signaling with T cells. T cells have to say, okay, I really mean it. I want you to do it. Please, B cells, do your job. You mature, you do your job. And then after that, then they have to mature. They have to change their genetic engineering. They have to alter the way that their genes are configured. They have to develop memory B cells. And then finally, they have to be able to make a great deal of antibody. And then finally, they have to be able to nestle down as a memory B cell or a plasma cell in your bone marrow. They have a very difficult life. And what that means is, of course, every single one of these cell interactions and cytokines and other cells, such as T cells and dendritic cells, and where they have to go and how they have to get there, is difficult. And that's why it takes so many genes to really make this occur, because it really is a very tough operation. So let's just go back and take a big step back for the moment, genetic questions. So first of all, in the United States, what proportion of patients with CVID as a family member with the same diagnosis? And even though I just told you these are what we call autosomal dominant in the United States, the honest fact is, in my practice, less than 10% of patients will have another family member. It could be it hasn't yet been diagnosed, but it also means it wasn't very clinically significant as that point of time. Will researchers ever define all the genetic mutations that cause CVID? Maybe not. I'm struck by the fact that we're 30%, but I also know that some of my patients for which I would very, very, very much like to know the genetic underpinnings, I don't see it yet. And so we keep looking, we keep looking. So will we? I hope so, but I don't know that we will. Will the knowing those mutations help to figure out what you're supposed to do about it? Yes, it can. There are situations, and it works out to be somewhere around 5 to 10% of the patients that I know. When you do know the gene, you actually can do a little bit better job because you know that there's another treatment that would really aid. It does not mean that person's going to go off gamma globulin, most likely, but it will mean that we'll think of something else that will take sort of the load off. The autoimmunity can be better controlled. The inflammatory disease in the intestinal tract can be improved. The lungs can be improved. And so it's very, very important in a way for us to know those cases because I wouldn't want to miss that. So I guess you might be wondering, should I have a gene test? Some of you probably have. And if you haven't, then you could say, well, is it worth it? Probably will not mean that you'll be off gamma globulin. You'll probably still need to be on antibiotics on occasion. But in a few cases, the gene might suggest the added helpful therapy, which I just said. Sometimes it might even help in family planning or even, trying to decide what to do in a family. I've seen that happen as well. But I have to really point out still that about 70% of the time, I really can't give you an exact answer. And so you would have to put up the fact that 70% of the time it might not come up with anything. But sometimes that's useful too, because in a way, if you know that you don't have anything that in 2022 or 23 we know is a problematic gene, it could free you up a little bit to think, okay, if I don't have anything right now, I can get some tests later, but in the meantime, I've got nothing that I would pass on, and it wouldn't be found in my family either. So these are kind of the conclusion slide, which is it is really one of the more common of the primary immune defects of man. And the standard treatment of good doses of gamma globulin really lead to greatly enhanced medical care. There's just no doubt about it. You still need antibiotics. We use antibiotics very, very freely. And most patients, I have to point out, having said all the things I've said, I have to tell you that most of the patients that I see are either in school now, or they're working full time, or they've retired because they felt like it. And it was time and they just felt like it and they're traveling or doing something else they want to do. So most of my patients, the one I've seen over this long period of time, are actually doing pretty much what they normally would have been doing. Genetic studies revealed causative factors in about 30%, but in most cases, there are no other members of clinically important immune defects, and something just take in. So thank you very much for the opportunity to talk to this wonderful group. I hope we have some questions in the chat room.
All right, wonderful. Well, thank you so much, Dr. Cunningham-Rundles, for that in-depth overview of CVID. We do now have some time available for Q&A. Before we begin, though, please remember that everyone's treatment and condition is unique. The information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. All right, so we've gotten some great questions so far, and we're going to go ahead and get started. All right, first question. How common is it for someone with CVID to have low IgG and low IgM with normal IgA levels?
It's pretty uncommon. It does occur, but it's pretty uncommon, honestly.
Thank you.
Can't give you a number.
Sure. All right, next question. This individual says, I have CVID and CTLA4 mutation. How often does this happen? What are additional complications slash symptoms? And what are additional treatments and prognosis?
I think about of ours with genetic findings of that particular gene, overall, it's about 6% of the patient population overall. It's not uncommon, but it's certainly very far from insignificant. It's one of the more common areas in which CVID appears. And what happens is that you've lost the brake on your T cells, is the point. The T cells simply can't slow down. And what that means is there can be extra amounts of inflammatory complications. In other words, the lymph nodes are too big. There's some lymphocytes that have decided to go into the spleen. There's more autoimmunity. There may be granulomatous disease because those macrophage cells are actually overactive as well. I think these are the issues that are most common. And when you know that there is a biologic that can be helpful and has been published to be helpful in the CTLA4 mutation situation, it just supplies that break that's missing. It's a break in the tube, honestly.
Thank you so much. All right, next question. This individual says, there seems to be a population of CVID patients that have traditional history of infections, and then there is a CVID population that not only has the history of infections, but also autoimmune diseases that add to the complexity of care. As genetic testing becomes more widely available, do you anticipate that CVID will become subdivided into those two different sort of patient populations?
I suspect so, but I think the division that we were hoping for was that the genetics would help us divide that in a logical and molecular way. And honestly, that hasn't happened. In other words, anything that the immune system has as a mutation has got the capacity of presenting with autoimmunity. So although you would think that the genetics should tell you what compartment and what would be the clinical presentation of that patient, it actually doesn't work out that way. So I understand what the person is asking, but I don't think we'll ever probably categorize it quite that way. Autoimmunity is about 25% of my patient population. Some have genes, some of them with the most rampant autoimmunity, I don't have a genetic understanding of why. So it could be that, we just say it's autoimmunity, CVID, and then segregate that separately. But I think at the moment we're trying to get molecular, really, tell you the truth.
Thank you so much. All right, and next question. This individual says, I have CVID and was just diagnosed with collagenous colitis. I'm not responding normally to the typical medications that they put on people for these types of flares. How do I help my GI doctor understand that my condition is unique and I need a different approach to my treatment? All of them seem to get frustrated with me and tell me to live with the symptoms.
Right. I think GI disease is one of the more problematic ones because we do have very, very, very large numbers of patients with this problem at Mount Sinai. And we've been using quite a bit of the biologics. And I would say some of the publications on the biologics have said that this is marvelous, this is a new therapy. And then we end up trying it and we think, yeah, but not so much. So unfortunately, we haven't cracked that GI situation either, but we tremendously use our inflammatory bowel disease colleagues to help us with these patients, I must admit. And I hope that person is going to somebody who's very, very familiar with significant and difficult inflammatory bowel disease. I would say everyday gastroenterology is not. It would be better to see a specialist in inflammatory bowel disease because they will come up with perhaps additional treatment options that haven't been explored yet.
Thank you so much. All right, next question. In CVID, do you know what causes the spleen and or liver enlargement without being related to alcohol?
Well, in my own mind, I explain the spleen to myself because it's predominantly B cells. It's B cells and cells that are T cells that are trying really hard to tell those B cells, please work harder, and the B cell, I'm sorry, I can't. So in a way, it's a little bit of a compensation, I think. I think the spleen gets large because it's containing those immature cells that are being actually insulted with a certain amount of bacterial debris from the GI tract, and they are doing the best that they can. You have to understand that I have a little bit of a cartoonish view in my mind about the way the B cell, the antibody is working. In other words, it's trying so hard and sometimes not very successfully. But on the other hand, it doesn't stop it from proliferating. And that's what you have, is you have the B cells, the baby B cells are proliferating, making more of themselves, and yet they really can't finish the job. So the immune system is always trying to cope with a difficult situation. And I don't think the spleen being large is necessarily a bad thing either, because if you think about it, the spleen is actually a filter. So that's one reason I'm not very interested ever in doing a splenectomy, to be honest, for that very reason. Now, the liver also is a bit of a lymphoid organ, and the same thing is occurring in the liver, which the liver is taking extra pressure because, again, it's absorbing debris from the GI tract, which it can't help but absorb because the mucosal immune system is broken as well. And the liver is seeing a great deal of inflammatory material it doesn't really know how to cope with. So the liver is trying very, very hard at the same time. It can lead to difficulty, I admit, and that's something that's worthy of a great deal more consideration because, in fact, that's some of our research studies is on that very topic as to why does the spleen take that kind of a hit as well.
Thank you. All right, next question. Do you have a thought on patients diagnosed before the age of 4 who continue to have common CVID comorbidities? Do you suggest that it's a different diagnosis?
If it started before the age of 4, I'm pretty sure I would want some genetic studies. Because if it's a very early onset, you may find one, you may not, but it could be we might know that in 2 years or 3 years. But with a very, very early onset, it's one of the reasons why a little bit of a genetic overtone is a little bit more suspicious.
Thank you. Next question. What is the impact of low bone marrow with CVID, or is it secondary to CVID?
I'm not sure what they mean by low bone marrow precisely.
We can chat them back and see if they can specify. In the meantime, we'll do the next question. This individual is asking, I wonder if you have seen cases of CVID with very high IgM that is not classified as hyper IgM.
I have actually. And in those circumstances, again, it's first of all, you want to be sure it's not clonal. That's one thing. The other thing is that on occasion, the IgM can be high if that person has not really gotten quite enough IgG in their blood, because the immune system is saying, okay, I can't make that IgG, but I'll just make a little more IgM for you instead. So it's worthy of thinking about either clonality or the IgG is not enough. And then the last one is, if it's not classified as genetic, I'd like to know whether that person had a complete genetic study on that topic. We have ourselves, I think, 1 or 2 patients with very high IgM that I don't have a genetic cause of. I'm sure there is something there, but the IgM is very high. It's very over 1,000. And of course, that's extremely unusual. In that circumstance, it could be that there are a number of extragerminal centers that are trying their darndest to make gamma globulin and perhaps being pushed to do that either by bacterial DNA or by other substances in the blood. But that's either genetic or another gene that we haven't thought of yet, possibly. So that person, would be very interesting to further study because there's more there. There's something to be said about that.
Certainly, thank you. All right, and it looks like this is our last question, although if you still have them, feel free to keep sending them through. Okay, I see a couple more coming through. That's great. All right, next question. Can a child of someone with one type of immune deficiency have another type that is different from their parents?
It could be the case, but you could say that a person who's CVID may have a child who's IgA deficient because, again, it's just a version of the same immune deficiency, isn't it? So, and I guess it's not impossible for a person with CVID to also be, if you're a woman, to be a carrier of an X-linked disease. So it surely is not impossible to be 2 diseases in one family. One would want to do genetics just to say, tell me more about what that is. It could be, for example, CTLA4, for example, or STAT3 mutations can look so different in one member of the family than another. In fact, it's the same gene, it's just that had a different clinical outcome. And so you have to also sort of take that apart as well. That could be the case.
Thank you. And I do want to let everyone know we actually have a session on genetic testing this afternoon. So if you'd like to check that out and maybe get some of your questions addressed there, we encourage you to do so. All right, next question. What percent of people with CVID do you think are misdiagnosed, and what do you most often see that it actually ends up being?
It could go either way. I mean, one thing I think is pretty interesting is that I have seen people diagnosed as CVID in their younger years. And then I end up seeing them when they're 25 or 30, move to New York City, and their insurance says, "Oh, you sure? You got to check it for sure." And I see the IgA and the IgM as normal. And I'm thinking, I don't think that's CVID, honestly. So I stopped the gamma globulin, and in 5 months later or so, retest all the antibodies. If they're normal, then in fact, that person was given the diagnosis of CVID and they held on to it. But in fact, it wasn't really CVID, it was just a physiologic immaturity. So I have seen that occur. It could also be that in the past we called something CVID, but was it a low-grade lymphoma? You could make the mistake early on into thinking that. It a little bit more commonly happens the other way. The patient has a lymphoma and then afterwards somebody says, by the way, I think it's CVID. And we never know because the person never had a workup before the lymphoma was treated nor even diagnosed. And so you don't know what the real basis was in the very beginning.
Thank you. And going back to the question about bone marrow, thank you for following up in here. So that individual had asked, where did it go?
It was a low bone marrow question.
Yes, about low bone marrow. And then they followed up and they said, okay, just to clarify, so their bone marrow biopsy indicated hypocellular, similar to someone in their 80s versus their actual age of 45.
Right. So what you might think about is either that person has been on a steroid, perhaps, or something that really gave the bone marrow a little bit of a calming down way too much. That might be one thing. The other thing could be that there could be a genetic bone marrow failure syndrome. About, 3 to 5% of our patients have a gene, which means the bone marrow has a hard time making a living. And there's a DNA recombination defect. I've seen that a few times. I noticed it was reasonably common actually in the Iranian population as well. In other words, the bone marrow has a little bit of difficulty with the recombining of genes in general. And what that meant was the bone marrow is a little bit skimpy. So it could be medication, or it could be there is a bone marrow, failure syndrome of some sort.
Thank you, and thank you to that individual for setting their clarification. All right, next question. This individual says, I have been recently diagnosed with CVID with the autoimmune portion of it, and my spleen is enlarged. Over time, will your spleen decrease and go back to closer to the baseline?
No, answer is no, it never will. It'll always be larger than normal. It might be a little larger sometimes than others, but it'll be generally large. And it's not a balloon, remember, it doesn't break easily. People always think the spleen is large and it could pop. No, it doesn't pop.
Thank you. Excuse me, next question. What role do T cells play in CVID patients?
A big amount. As you can see, the B cells really don't work at all unless you have good T cell activity. T cells are really crucial to making antibody in pretty much every step of the way. And so for the longest period of time, especially in the early periods when I was looking at CVID so carefully, looking at from the T cell side, you can see there's plenty wrong with how the T cells are really not supplying what we call T cell help. And that includes not only cytokines, but it includes direct contact of those cells as well. There's some interesting work that's coming along on that particular topic of a company that's thinking about if the T cells are part of the problem, then maybe we could juice up the T cells a little bit. So there's a company that's actually working on that.
Thank you so much. Next question. What can other causes of hypogammaglobulinemia be with IgG around 500, so no standard deviation of 2, and no measurable IgA?
The real big deal there would be you have an IgG of 500, but is it good stuff? Is it binding to vaccine antigens? Does it have antibody to measles, mumps, rubella, tetanus, diphtheria? In other words, or is it more or less useless 500 material. Because if the IgA is very low and the IgG is in that number, the next thing I would probably want to be sure about is the IgG subclasses, because you also want to know, was there a skewing of those subclasses? If the IgA is 0, about 12% of people have an IgA2 deficiency as well. And that makes the IgG a little bit low. On the other hand, it makes the antibodies in certain categories very poor. So there's more to know about that. One is the antibody and the other is the subclasses, but the antibody is crucial.
Thank you. Next question. This individual says, I have CVID and am on IVIG. I believe I might have, I think it's Sjogren's and lupus or rheumatoid arthritis. How can I get properly diagnosed since most testing is antibody-based?
That person is so right. I'm glad they know that, because rheumatologists frequently are trying all these antibody tests on a patient on gamma globulin. You'll find all kinds of autoantibodies in the blood that don't belong to you, and it's useless information. Unfortunately, with Sjogren's, the only way really is something like lip biopsy to determine whether that salivary gland abnormality is present. The antibody testing is useless. So it's going to be a clinical diagnosis, unfortunately.
Thank you, and thanks for that great question. Next question, how do our doctors check how our T cells are doing?
That's kind of a tough one. If you're not on gamma globulin, then it's reasonably easy to know that your T cells are doing something, at least if you're making antibody to a few things. One of them being perhaps the COVID vaccination or a few other vaccinations, then you'll know your T cells were at least operational. Other than that, the previous test for T cell function is by that method called mitogens. It's a test called mitogens and antigens. And what you do is you take those T cells and you separate them, and then you look to see whether they can proliferate if they're given a stimulating signal. And that's been kind of one of the standard ways of doing it, I guess, for the last 40 years or so. So your doctor could do that as well. The other one that we frequently do is something called the CD45 RO-RA test. We look to see whether the T cells that you have are actually cells that are in your age group compatible with those that are sufficient numbers of naive memory B cells. In other words, the CD45 RA cells are T cells that are ready to work. They got the job done. They can work. CD45 RO cells are cells, I'm exhausted. I'm sorry, I can't do anything more for you. And that's just a flow cytometer test, and it can be ordered. A lot of laboratories run that one. So there's two ways. One is functional and the other is by just their phenotype under the flow cytometer.
Thank you so much. All right, and it looks like this is our last question, unless anyone else has others, please put them in. This one is, there seems to be a number of conditions that people with CVID have in common that are not talked about, like EDS and POTS. Is there a reason for this?
EDS, Ehlers-Danlos, right? Probably. I'm not really sure. I think PCOS might be relatively common anyway. I've never put the numbers together. In our own patient group, I've seen a few. I wouldn't say in our own group of 700 or 800, that's been a predominant theme. So I think that, I don't know if that would hold up to scrutiny if you really did a USIDNet query, for example. It would be an interesting query, by the way. In other words, how common is PCOS in the patients that the USIDNet has collected, or Ehlers-Danlos? That way you get data from across the country, not one doctor's opinion about it. I wouldn't want to give you one doctor's opinion. My own opinion is that's a very uncommon connection. But again, it's better to get US data, I think, rather than one view.
Wonderful, thank you. And we do have a couple more coming in, so we're going to keep going as long as you're okay to continue, Dr. Cunningham-Rundles. Also, I see we have a couple folks raising their hand. Hand raising is not enabled on this platform, so if you have questions, We encourage you to please put them in the chat. All right, next question. This individual says, I was diagnosed with CVID, but I also have low T cells in the 230 to 300 count, plus chronic low white blood cells. Genetic testing was not helpful. AIDS and leukemia have been ruled out. Unfortunately, infections persist despite IgG treatment on Hizentra. What could it be, and do you have any treatment ideas?
Usually that's a spleen sequestration question. In other words, if your spleen is big, then those cells are hanging out in the spleen instead. It's a traffic problem. And usually that's what it is. That person needs a sonogram of their spleen because I think they're hypersplenic.
Thank you. All right, next question. Can you say more about how to diagnose lupus in someone with CVID?
That's going to be a clinical diagnosis exclusively, unfortunately. You can't use any of the antibody tests, which I'm so glad that person raised that question because that's really key. It's very difficult to make that diagnosis. You have to go to a clinician who can use only clinical criteria. Diagnosis of lupus is not exactly easy either, even in people who have lupus, as you might know. A little bit of anti-nuclear antibody and plus a few other symptoms, might not quite do it. So I can't evade the answer, which is that it's not very easy to do that. The honest truth.
Thank you. Next question. This individual says, I have been diagnosed with CVID with my IgG averaging 550. I'm not on IVIG and I have few infections, but I have severe psoriatic arthritis and am on Enbrel. Would I benefit from IVIG?
For the psoriatic arthritis, no. I would say no. But if you have an IgG of 500 or so and the antibody is very poor, then I would do that anyway, because I would go by antibodies at that number of 500. 500, you may have good antibodies. Measles, mumps, rubella, tetanus, diphtheria. Don't just use Pneumovax, use a whole bunch of things. If the antibodies are pretty decent, then antibody is really not going to be necessarily helpful. But the psoriatic arthritis will not improve with gamma globulin.
Thank you.
The wish.
All right, next question. Are there any promising treatment algorithms to treat chronic noroviral infections with CVID? Also, how close is the medical community to establishing a noroviral vaccine, and will it even work for people with CVID?
Yeah, that's actually one of my favorite questions, and I'm so glad that one got brought up as well. Norovirus is actually one of the biggest problems that I know about right now. I think it's absolutely dreadful. And we have had absolutely decimated patients from norovirus. We're extremely upset about norovirus in our community. I have patients on TPN, which is total parenteral nutrition, which is feeding by vein because of norovirus. No, we have no treatment that really works. The things that were published, I think, don't work. I think everybody tried it, but nobody went out and published it and said, oh, by the way, that doesn't work. So it seemed like everybody is going through the same routine. I do have one or two patients who did get over it. And I have met a patient in London who did get over it as well. So it's not impossible to get over it, but we have no treatment for it. Will a vaccine work? I doubt it. It would be probably worthwhile trying. If it helps on the T cells at all, it would be useful, but you won't be making an antibody. And if the point of the vaccine is an antibody, I think it's not going to work for us. We need it though.
Thank you. All right, next question. If you have the PIK3 gene, does that mean that you have PIK3 delta syndrome? Is that gene the cause of my CVID?
The answer is yes. You know, when we tell an insurance company at CVID, they get it, they get the point. They know, okay, fine, you need gamma globulin. I understand that the PIK3 gene, the APDS gene, has finally got a ICD code. And so finally, insurance companies will understand that, yes, you need gamma globulin if you have that code. And yes, it's much more precise. But at the moment, insurance companies got to learn that. And at the moment, if you call it CVID and APDS, you'll be doing probably a little bit better, because you don't want to confuse the insurance companies right now. you want them to give them what you want and what you need and not argue with you.
Thank you. And I believe we do have a session on APDS in the on-demand section of the conference website. So
Yeah.
if that individual wants to explore that, please feel free. All right, next question. Since the average age of diagnosis for CVID is 37, what studies can be done to determine how pregnancy impacts CVID and vice versa?
That's again a really good question, because if you say to yourself, well, women come in the door in their 30s, you think, what else is happening when you're in your 30s? Gee whiz, you just had a baby. I don't think there's any connection, to be honest with you. But I don't think any of us know that, in any clear-cut way. I've had plenty of patients come in before that period of time as well. I honestly think it's just a delay in diagnosis. And I don't know if you know this or not, but in general, women have a little bit more antibody than men do anyway. It's just that's the way women are made. For any given vaccine, females do slightly better and they have more IgM. It could be that, in fact, because females have slightly better antibody forming functions anyway, they're diagnosed later because their system, can carry on a little bit longer. I'm a little bit more attracted to that idea than pregnancy affects, the diagnosis here.
Thank you, and great question.
Yeah.
All right, next question. What symptoms are associated with CVID with low subclass 2 and 3?
Well, low subclass 2 depends on how low is low. Some of the labs vary quite a bit. I'm talking way under 100 now, under even 50 or so, or less than that. Subclass 3 doesn't have a particular meaning. Subclass 3 is extremely common in just human beings walking around, who are going to work today and are absolutely fine. So subclass 3 doesn't have a particular role. Subclass 2 only matters if you can't make an antibody to carbohydrate or to vaccine antigens. So it's a version of an immune deficiency, yes, but unless the IgA and the vaccine titers are poor, I don't know that I'd call that CVID at all.
Thank you. This individual asks, can you talk some about high IgE and immune deficiencies?
Well, most of the patients that have CVID don't have a high IgE because that's the allergy antibody. And in a way, if you have a high IgE, you don't have CVID. And a paper actually came out on that very topic. I think it's Jennifer Lawrence, actually, Dr. Lawrence published a paper on that. So if the IgE is high, it means your antibody making B cells are doing a pretty good job making that one. And if they can make that one, they can probably make IgG, A, and M. So there's a whole classification of immune deficiencies that do have high IgE. It's just not CVID. It's another group of things altogether.
Sure thing. All right. Well, thank you so much, everyone. I know we didn't get to everyone's questions, but we are nearing the end of our session and need to start wrapping up. So thank you so much, Dr. Cunningham-Rundles, for this wonderful presentation and for answering everyone's questions. We again apologize that we couldn't quite get to everyone, but we really appreciate the engagement and these great questions. And thank you so much. So it's been an honor to have you join us today, Dr. Cunningham-Rundles. Thank you everyone for being a part of today's session. And we hope to see you at the next conference session. Thank you so much. Have a great rest of the day.
Thanks very much. Thank you everybody for attending. I appreciate your attention.